Can the straight leg raise test be improved? One of the most commonly used tests for the low back is the straight leg raise, yet although it's been found to be sensitive, it's not specific for disc herniation and nerve root involvement. It then seems obvious that either other tests or modifications or extensions to the ESLR are needed to increase the specificity. A new study investigates 2 extension maneuvers for the ESLR and compares them to patients' MRI findings for disc herniation or nerve root involvement. The title of the publication is Extending the Straight Leg Raise Test for Improved Clinical Evaluation of Sciatica, Validity and Diagnostic Performance with Reference to the Magnetic Resonance Imaging. This was published in BMC Musculoskeletal Disorders in 2021. The extended SLR differs from the traditional SLR in that the responses do not need to travel below the knee. These responses do not need to occur before 70 degrees, but can happen anywhere from 0 to 90 degrees of hip flexion. A structural differentiation maneuver is then added to the SLR. If the symptoms are located distally below the knee, then you add hip internal rotation. If the symptoms are provoked proximally in the buttock or hamstring area, then you add ankle dorsiflexion. So what's a positive extended SLR? At least part of the patient's symptoms are first provoked or present symptoms are increased by 30% with the traditional SLR, but then a differentiating movement that moves the nerve roots but not the spine increases the evoked symptoms using either ankle dorsiflexion or hip internal rotation. So where did the traditional range recommended for the SLR come from? The usual 30 to 60 or 70 degrees. Prior cadaveric studies indicated little dural tension until 30 degrees, therefore positives below 30 degrees were not indicative of disc herniation as a cause of low back pain, with a hypothesis that dural tension was the cause. But a study published in Spine in 1995 retrospectively looked at the baseline results of the SLR on patients with surgically documented nerve root involvement. In other words, patients who had surgery for nerve root involvement. They found that the SLR was positive in 42% of patients from 0 to 30 degrees. That's the range excluded in the traditional interpretation of a positive. The SLR was positive in only 26% of patients from 30 to 60 degrees. The extended SLR has already shown very high inter-rater reliability between and among examiners. But curiously, this study also stated the ability to detect sciatic patients even when used without any knowledge of patient history or other clinical data. That's usually not part of a reliability study. The intent in general study design was to assess the association between the ESLR or SLR results and pathological findings on MRI, determining the odds of having pathological findings based on the comparison of test results. So this was calculated as an odds ratio. The odds ratio was calculated for lumbar disc herniation or nerve root compression using a binary logistic regression analysis adjusted with subjects' age, gender, height, and weight. So frankly, what does that statistical jargon mean? Well, it's odd that they don't use in the results the standard measure of test validity, which includes sensitivity, specificity, positive and negative predictive values, and likelihood ratios. Instead, they use a statistic usually reserved for risk assessment. So in other words, it could be translated to what is the risk of having a disc herniation or neural compression if you have a positive test. Odd indeed. There were 2 groups. The sciatic group had a combination of sciatic symptoms and clinical findings indicative of sciatica, a positive extended SLR on clinical exam, and a radiating pain to the lower limb either below or above the knee. The control group either had local low back pain, greater trochanteric pain, or growing pain, with or without hamstring tightness, but no radiation into the lower extremity. And there were no signs of sciatica on clinical examination. The extended SLR was negative with no neurologic findings indicating a radiculopathy. For the exclusion criteria, there were no spinal tumors or malignancies, no problem with incomplete knee extension, previously known other joint involvements from rheumatoid arthritis or metabolic bone disease, age more than 65 or younger than 18, and the subject's refusal to give informed consent or claustrophobia or unwillingness to undergo MRI. So who was the study population? Well, this population consisted of the same 40 subjects that participated in the ESLR inter-rater reliability study. So again, two groups, 20 in the sciatic symptomatic group and 20 in the control group, which consisted of non-specific low back pain and hip pain patients. There was a total of 28 lumbar disc herniations and 25 neural compressions visible in the subject's MRI scans. All subjects in the control group were evaluated as negative with both the ESLR and the traditional SLR. With the sciatic patients, 10 out of 20 were judged negative for the traditional SLR due to either hip flexion angle reaching over 70 degrees when the first evoked responses occurred, or the evoked symptoms did not reach below the knee. So the findings for the positive extended SLR subjects were that 17 out of 20, 85%, had lumbar disc herniation, and 15 out of 20, or 75%, had nerve root compression on their MRI exams. There was a very high incidence of false positive findings on the MRI with the ESLR negative group. 11 out of 20 had lumbar disc herniation, and 10 out of 20 showed nerve root compression without clinical signs of sciatic radiculopathy. That's about half. Now, this significantly affects the test's predictive value. In comparison, among the traditional SLR positive subjects, 9 out of 10, or 90%, had lumbar disc herniation, and 7 out of 10 had nerve root compression, 70%, visible on MRI. Whereas the SLR negative group, there were only 63% who had lumbar disc herniation and 18 with neural compression. But these are false positives on the MRI. So how do we interpret and utilize these results? Well, a positive result on the extended SLR was strongly associated with both lumbar disc herniation and neural compression as an odds ratio for lumbar disc herniation of 8 and 5.6 for neural compression. On the other hand, the odds ratios for traditional SLR results did not reach statistical significance with either lumbar disc herniation at 8.3 nor nerve root compression at 2.4. In other words, regardless of the odds ratios, the differences could have occurred by chance with the SLR and are therefore negated as a finding that could be trusted. So the researchers found that a positive result with the extended SLR shows a high validity and is strongly associated with both lumbar disc herniation and nerve root compression seen on MRI. There was also a very high incidence of false positive findings on the MRI in the control group. This discrepancy leads to poor overall agreement between the MRI and the extended SLR or traditional SLR results. However, the extended SLR's odds ratios for the likelihood of nerve root compression was 5.6 and only 2.4 with the traditional SLR. So we know several things based on this study. The extended SLR, when positive, is strongly associated with disc herniation or nerve root involvement compared to the traditional SLR. So the value is only in the test being positive to rule in, but not for a negative test to rule out. However, because there are so many false positives on MRI, in this case meaning finding on MRI with no clinical manifestations of nerve root involvement in the patient, the tests do not reflect MRI findings. So the question is, why even consider a control group in this study? In other words, would you perform the SLR or extended SLR on patients without radiation or other indicators of nerve root involvement? I think not. So although interesting, it only introduces noise into the interpretation given the high percentage of MRI findings in asymptomatic individuals. So it really doesn't clinically matter if we miss these patients, meaning we wouldn't or shouldn't be performing these provocative tests with no clinical indicators. But wait, also I found it odd that they would use odds ratios for these calculations. These are generally used for risk studies, not for diagnostic tests. What are the usual measures of diagnostic validity? Sensitivity, specificity, positive and negative predictive values, and likelihood ratios. Well, they actually provide sensitivity and specificity in two tables, but they are actually miscalculated. One table is for disc herniation, the other for neural compression, which of course will overlap. They state that sensitivity for a disc herniation for the extended SLR is 85% and specificity is 45%, and for the SLR 90% and 37%. We're going to focus on the extended SLR. When I calculate the values using an online diagnostic test calculator, as you can see here, for the extended SLR sensitivity, it's 61% if you round up, and specificity is 75%. Curiously, what they calculated was the positive and negative predictive values of 85% and 45%, respectively. So why did they do this? Normally, you compare a test finding to a gold standard or reference standard for that pathology. In this case, the test should have been the ESLR, and the reference standard for the pathology should have been the MRI. Instead, they flipped this and assumed that a positive extended SLR indicated disc pathology and compared that to a test positive finding of a disc herniation or neural compression on MRI. Completely backwards in logic and incorrect, making the MRI the test and the orthopedic test the surrogate for the pathology. In essence, switching the focus to does the MRI reflect what is found on the exam. So again, for neural compression and the extended SLR, they generated a positive and negative predictive value, not sensitivity and specificity. So they state it is 75% and 50%. When you do that, the more individuals with the pathology, the higher the positive predictive value. And the way this study was set up, through its design structure, the group with the positive extended SLR was biased with patients with disc pathology and neural compression. So we can see here the sensitivity is actually 60% and the specificity is 67% if it's rounded up. This is why their sensitivity numbers were so high. Remember, it was actually the positive predictive values they were erroneously calculating. Here is a table of the correct calculations for sensitivity and specificity for the SLR and extended SLR for disc herniation and neural compression. So with this new information, what's changed? The sensitivity of both the SLR and the extended SLR are not good, the SLR being virtually useless. It appears the SLR is very specific, though, interestingly, the opposite of the finding of most studies. Very confusing. Why? Well, again, the inclusion of participants you would never test with an SLR or extended SLR, and therefore would never image. So, how do we salvage usable information from this flawed attempt? What can be shown is that there is a strong correlation between the extended SLR and MRI findings of pathology. The problem is they combined individuals with likely pathology, those with a positive SLR or ESLR, with a control group that by their clinical presentations were highly unlikely to have MRI findings. And then that introduced a substantial number of false positives on MRI. So remember the correlation, though, for the extended SLR patients. 17 out of 20 or 85% had lumbar disc herniation, and 15 out of 20 or 75% had nerve root compression on their MRI scans. There was a very high incidence of false positive findings in the MRI with the extended SLR negative group. 11 out of 20 had lumbar disc herniation, and 10 out of 20 showed nerve root compression without clinical signs of sciatic radiculopathy. That's about half. This significantly affects the test's predictive value. In comparison, among the traditional SLR subjects, 9 out of 10 or 90% had lumbar disc herniation, and 7 out of 10 or 70% had nerve root compression visible on the MRI. But for the negative SLR patients, 19 out of 30 or 63% and 18 out of 30 or 60% showed false positive lumbar disc herniation and nerve root compression findings on the MRI respectively. This very high false finding influences its utility in resulting sensitivity and specificity calculations. Bottom line, the correlation between a positive straight leg raise and extended straight leg raise strongly predicts whether there will be a pathology on an MRI indicating either disc herniation or no compression. The researchers should have only studied those patients to see this correlation. The flaw was when they included the control group, those patients we would never do testing on anyway based on a clinical presentation that did not suggest disc pathology or no compression, and we therefore would never order an MRI and therefore would never have to deal with the false positives that interfere so much with the results.